Good morning.
No, I think I have one. I'm trying to figure out exactly.
Today, we begin the second in a series of hearings conducted by the Joint Fiscal Committees of the Legislature regarding the Governor's proposed budget for fiscal year 2016-2017.
Our next speaker is Senator John DeFrancisco.
Good afternoon.
Thank you.
Mr. Helgerson, now you got to pay attention to this, Marty, because Marty always says that I never think about Brooklyn. That back, I'm sure you don't remember this letter, but you certainly remember the topic, and you did receive a copy. November 12th, to a letter from Tammy Ramos, Practice Administrator, Hematology Oncology, Associates of Brooklyn. And they list a whole slew of other, including some from my area. And basically, and I'm going to read this because I'm not an expert in this area, that the Medicaid reimbursement policy for Medicaid, Medicare, duly eligible individuals was changed. And it was announced in July of 2015 that Medicaid will no longer reimburse partial Medicaid Part B coinsurance amounts when the Medicare payment exceeds the Medicaid fee or rate for that service. You're familiar with that?
Yes.
Was that implemented, first of all?
I know there were some concerns about the method of implementation, but I believe, yes, it has been implemented.
Okay, well, that was a bad idea. Because there's a lot of, and this is absolutely serious, some practices based upon this new rule have been estimated to lose approximately $800,000. These are medical practices. And you know what happens when they don't make money and they lose money? They don't take the patients anymore. And guess where they go? Hospitals, which is certainly not the best setting for someone going through chemotherapy. And secondly, it's much more expensive. So sometimes there's intended consequences. And later on, there's going to be a speaker from the Community Oncology Alliance. And I'll send you a copy of his testimony because it'll be much more detailed than what I'm saying. But I would really, truly, and this is not being facetious, if you'd please take a look at it, because we're going to end up with more expenses and we're going to end up with a much more substantial problem. Fair enough? Okay, I appreciate that.
Community Oncology Alliance, Ed Ocon and Mary Ann Rofer. How close did I get in? Next will be Empire State Association. If you move down, you can speed it up. We've got a lot to go.
Good afternoon, although I guess I should say good evening.
I messed up your name.
We thank you for the opportunity to share our views on the adverse impact that Medicaid payment cuts will have on patients with cancer in New York State who are covered under Medicare and also eligible for Medicaid. I am the Executive Director of the Community Oncology Alliance, a nonprofit organization dedicated to serving patients and providers in the community oncology setting, where close to 70% of Americans with cancer are treated. After my initial remarks on this critical issue, I will hand over this testimony to Mary Ann Rofer, who's the Chief Executive Officer of a large community oncology practice in New York that serves patients with cancer in the greater Syracuse area. Recent changes to the state of New York's Medicaid reimbursement policy for patients duly eligible for Medicare and Medicaid will hurt community oncology practices and the patients with cancer they serve. Specifically, we are concerned with the budget-cutting policy that Medicaid is now no longer reimbursing partial Medicare Part B coinsurance amounts when the Medicare payment exceeds the Medicaid fee for that service. Medicare covers 80% of the reimbursement rate it sets for cancer care, with patients responsible for the remaining 20%. For those individuals covered by Medicare who are also eligible for Medicaid, it is Medicaid that is supposed to cover the 20% coinsurance. That is the issue. Although New York Medicaid relented in not cutting payments for the 20% Medicare coinsurance for cancer drugs, it is now substantially cutting payments for the administration of chemotherapy and other vital services provided to the most vulnerable patients with cancer. that is seniors and those disabled individuals covered by Medicare. As background on this issue, community oncology practices like Mary Ann's have faced many devastating payment cuts at both the state and federal levels, such as the automatic Medicare budget sequestration cut in 2013. These cuts have slowly pushed more practices to close or be acquired by hospitals, consolidating the cancer care delivery system significantly. Over the last 8 years, nearly 40% of New York State's community oncology practices have closed clinics or been acquired by hospitals. The problem is that as the community oncology practices close, patients have to go to the hospital for care they could be receiving in the community setting. Patients that have been receiving treatment from the same practice, in some cases for years, face dangerous gaps in their care when they're displaced to the hospital setting. Furthermore, many studies have demonstrated that hospital-based cancer care is 153% more expensive than in the community setting. The consolidation of cancer care in New York State and across the country is already creating stresses on the nation's cancer care delivery system, with patients being displaced and cost increasing as cancer care is absorbed into large hospital systems. Now, New York Medicaid is adding to the stresses by paying a fraction of the 20% Medicare coinsurance for dual-eligible individuals. As it is, community oncology practices are reimbursed by Medicare for just 57% of the costs related to chemotherapy administration and related critical services. Additionally, many other services are not reimbursed at all, including psychological counseling, care coordination, supportive care, telephone support, and financial counseling. Community oncology practices simply cannot absorb additional payment cuts. They either have to send patients to hospitals or eventually close or merge into large hospital systems, in which case all patients end up being billed under the more expensive hospital setting. Taxpayers end up paying the price when that happens. Representatives from community oncology practices across New York State, from Long Island, Queens, Brooklyn, Syracuse, Albany, and beyond, are here today to say that this Medicaid policy change is extremely short-sighted. While it may save money in the short run, there is no question that costs for cancer care to New York State Medicaid and the federal Medicare program will go up dramatically. Tragically, it is the most vulnerable patients, seniors and those with disabilities, who get caught in the policy crosshairs. And when I get too caught up in the policy, it is my wife, who is a full-time oncology nurse, who reminds me of what cancer care is about: people battling a dreaded disease. Recently, President Obama and Vice President Biden launched a moonshot to cure cancer. We commend them for that and know that New York oncologists have and will continue to contribute greatly to that effort. But as we prepare for the battle tomorrow, we cannot forget the Americans, especially the most vulnerable New Yorkers, facing misguided public policy that threatens their cancer treatment today. I will now hand this testimony over to Mary Ann Ruffaro of Hematology and Oncology Associates of Central New York.
Thank you, Ted. I'm very grateful for this opportunity to speak with you today. As Ted said, I run a large, independent, private oncology practice in Central New York. It's been providing services since 1982, serving people of greater Syracuse area. We had 5,000 new patients last year and served 17,000 visits. We have a team of 16 specialists at our practice in four clinic locations in the area of oncology, hematology, and radiation oncology, as well as a plethora of professional clinical staff, of advanced practical care nurses, nurse practitioners, physician assistants, specialized oncology nurses, ancillary professionals. We have a doctor of physical therapy who also does our cancer rehabilitation program. Our mission is simple. It's to provide the highest level of quality care in a healing environment for the mind, body, and spirit of those patients dealing with cancer and blood disorders. Our goal is to offer the highest level, state-of-the-art technology, care, and treatments while meeting the emotional needs of our patients and their families. In taking care of the whole patient, we provide an array of clinical cancer diagnostic and treatment services in a highly coordinated and efficient manner, and I often say it takes a village to take care of these people. We have 270 employees to serve these patients. Our services include the administration of chemotherapy, biologicals, related cancer drugs, diagnostic imaging, psychosocial services, nutritional counseling. We do support groups for families, caregivers, provide radiation therapy, and specialty drug pharmacy treatments. We are extremely concerned with the payment cuts that Medicaid is now implementing for our patients, duly covered by Medicare and Medicaid. As Ted described, our practice has felt the brunt of these cuts after cut to cancer care, including the blunt acts of the Medicare sequestration cut. These types of cuts have real impacts on the cancer care system and in each of your districts. For example, our practice alone had to close a smaller satellite office a few years ago, and just recently, a few months ago, we had to close a satellite in Rome, New York, which is actually quite rural and is feeling the effects of us not being there, and they need to drive now into East Syracuse. It's been very difficult to absorb all of the cuts that have come our way in the recent years. The most recent Medicaid cuts are truly unsustainable. Community oncology practices with small populations of payments who have only Medicaid coverage accept losses in order to provide care to the needy. However, for many of us, dual-eligible Medicare Medicaid patients represent a large part, upwards of 30% of the Medicare population we serve, and this new policy will hurt us tremendously. For 4 of the practices joining me today in this room, losses from just this new Medicaid policy are estimated to be over $235,000 a year. And although that doesn't sound like much to you, with a budget of billions of dollars, it means a lot to us, and it will have an incredible impact on our ability to render cancer care to the people of New York. The services impacted by these cuts are critical to patient care and safety. For example, skilled nurses that administer chemo and care for patients while they receive treatment will fall under these cuts. They're essential to patient care, monitoring for dangerous complications, ensuring good treatment outcomes. In the short term, these cuts will cause practices like ours to cut back skilled nursing and similar key oncology administrative services, which is a very short-sighted way to achieve any quick savings. Or in the end, being forced to send these patients to hospitals for treatment because we can no longer take care of them and sustain the losses. The problem in our case is that the hospital simply cannot even absorb these number of patients. There's about 980 of them alone in our practice. I underscore what Ted related from my vantage point of running an oncology practice and keeping it viable. As a business person, I totally understand that it's about budgets and finances. However, fundamentally, it's about people. People I watch every day fighting terrible, often devastating disease. I watch them struggle with treatment, their own finances, and simply putting one foot in front of the other just to fight their disease. These Medicaid cuts will have devastating impacts on the most vulnerable of these patients. If you don't believe me, look at recent studies documenting the patients who are dual eligible for Medicare and Medicaid who face significant disparities in outcomes of quality cancer care. They're diagnosed at more advanced stages of disease, have lower 5-year survival rates, receive lower quality of care, and have poorer outcomes than people with insurance from other sources. I call your attention to a recently published study by the University of California, Davis, which we have referred to in our testimony. As an example, cancer patients in California who are dual eligible for Medicare and Medicaid had the lowest proportions of recommended treatment of breast cancer with radiotherapy and of colon cancer along with chemotherapy. In short, dual eligible patients end up being treated like second-class citizens, and simply, this is not right. If these Medicaid cuts being implemented now are not bad enough, the New York Medicaid has indicated that the cuts will be retroactive from July of 2015. And this means that we'll be required to refund, and yes, I do underscore the word refund, portions of reimbursements that we have been provided since July. Not only will this be devastating, it'll be a big, fat mess in our practice management systems for billing. We met with New York Medicaid last December. They listened to the facts we provided, but they said they were unable to do anything, and we now implore the state and the Assembly to help us in this dire situation. We're not just asking to stop additional payment cuts to mandate Medicaid to work, but also to work with practices across the state. Community oncology practices like ours have been leading the way in real payment reform with national insurance companies like Aetna, United Healthcare, and even Medicare reducing costs. Just recently, our practice received accreditation as an oncology medical home from the Commission on Cancer. This is very exciting and something that we're very proud of, and so should you, because there are only 9 of these practices in the United States, and we are the only practice in New York State that has achieved this. And so we hope that you are proud also. Given the special nature of cancer, the devastating impact of the disease, and the vulnerable dual-eligible population involved, we ask for a carve-out of cancer care services from these Medicaid cuts, including the suspension of the retroactive payments back to Medicaid. This will actually end up saving the state money as well as Medicare by keeping cancer care from migrating further into a more expensive hospital setting. This way, our practice can work with the New York State Medicaid in devising innovative solutions that provide quality, efficient cancer care to these dual-eligible individuals. Please, please let us work together for our patients, the New Yorkers you represent, not to mindlessly cut cancer care to the most vulnerable, but to improve it for generations to come. Thank you for listening, and I know we're out of time, but we'd be happy to answer any questions.
Thank you very much. Questions?
Thank you. Senator DeFrancisco.
Not so much a question, but I want to thank you both for being here. You weren't here in the morning when I had talked to the health commissioner and the head of the Medicaid department and told them that I would send a copy of your testimony to them because you'd be able to elaborate on this issue much more than I can. But the point is, if we are closing satellite offices where for people sick with cancer, that they have to travel many, many miles to get to your facility now, and if we keep this up, and the facilities like yours close, both of yours close, and all throughout the state, even in Brooklyn, as I told Marty Golden, and they close, then it means hospital care. And how short-sighted is it to spend 150, when that cost is 153% of the cost that you provide? It's just short-sighted foolishness and long-term big damage. So thank you. I know I've talked to Senator Hannan about this issue already, and hopefully we can generate the support and change some minds during this budget process because it's an essential issue. And I thank you for coming again.
Thank you very much, Senator.
Thank you all.
Kathy.
Thank you.
Senator Hannan.
Yeah, I just wanted to say, Senator DeFrancisco had said that, and you can tell he's really determined because he came back just for your testimony. This is an issue that we tried to solve, not go along with the administration's proposal last budget. And they kept on making us pay for it and pay for it. They had totaled $40 million. They cut it in half. We ultimately didn't have the last $20 million. So we understand the issue. We're going to try to fight for it here and make sure that it does not remain, because we do believe, as Senator DeFrancisco said, it's counterproductive.
Thank you, Senator.
Thank you
and I
very
just
much.
want to say that there's a tremendous amount going on in oncology payment reform that's happening across the country, as Mary Ann said. So we're ready to work with basically Medicaid in terms of transforming the Medicaid payment for oncology services.
And given your sophistication, I would get ahead of it. I would have proposals. I would make it to Medicaid, because I've read some of the stuff that CMS has tried to do, especially with private physicians and what's going on with oncology drugs in their offices. So if you get ahead of it, you can have it probably the most reasonable and sane you could get it.
Thank you. We've provided Medicaid with a lot of the information on these alternative payment models. Thank you very much.
Thank you very much.
Thank you so much.
Thank you.